and refractory multiple myeloma. There's been a dramatic progress in treatment of multiple myeloma with several new options. This slide summarizes the progress we have made. We have had multiple new drugs that are in development and have been approved recently. If you look on the left-hand side, for many, many years, we had just alkylators, steroids, and anthracyclines. Then came the IMiD and proteasome inhibitor era, where we had thalidomide, lenalidomide, pomalidomide, and then bortezomib, carfilzomib, ixazomib. And these have really had a great impact in the overall survival of multiple myeloma patients. Then the next step was the advent of CD38 monoclonal antibodies, particularly daratumumab and isatuximab, which have been approved. And they have really augmented our ability to treat myeloma patients, both in the newly diagnosed and in the relapsed refractory setting. More recently, there have been substantial advances in immunotherapy, particularly on the right-hand side, you will see anti-BCMA CAR T cells, chimeric receptor T cells, bispecific antibodies, and newer bispecifics. Together, we now have multiple options to treat relapsed refractory myeloma. So what we go through today is how we approach a patient when you have so many options that are available. How do we optimally combine these drugs together? Now, in blue are drugs that are not yet FDA approved, so keep that in mind. All the others in black font are FDA approved for the treatment of relapsed multiple myeloma. Now, this slide shows you the initial slew of clinical trials, randomized controlled trials, that showed that in patients with relapsed refractory multiple myeloma, if you use a triplet, you get better outcome than with doublets. So you can see here, the backbone of relapsed multiple myeloma treatment used to be just a doublet with either lenalidomide dexamethasone or bortezomib dexamethasone. And then we had multiple trials showing that using drugs like ixazomib, elotuzumab, carfilzomib, you develop triplets combining with either a lenalidomide dex backbone or a bortezomib dex backbone. And you can see here that with the triplets, we get better progression-free survival, better response rates. And so triplet treatment for relapsed refractory multiple myeloma has become a standard. Unfortunately, there have been no trials comparing one triplet versus the other, so it's hard to decide which triplet to use. And we use surrogate markers such as, comparing across randomized trials or looking at what the patients already had before in deciding which regimen to use. Now, a number of our patients have already been on lenalidomide and bortezomib, and they have already been exposed or are refractory to lenalidomide and or bortezomib when they are in the relapse stage. So the next set of studies, randomized controlled trials, looked at what can be the other partners for these new drugs besides bortezomib and lenalidomide. And here you can see examples of 4 randomized trials which looked at combinations using either pomalidomide or carfilzomib instead of lenalidomide and bortezomib. And again, you can see that the triplet regimens provide better progression-free survival, better response rate than the doublet. So we have expanded our options for relapsed myeloma patients with triplets, not just using a len-dex or bortezomib dex backbone, but also with carfilzomib dex or a pomalidomide dex backbone. I often say that the specific regimen you choose at the time of relapse will depend on multiple factors, and I have used the acronym TRAP. TRAP is timing of the relapse. When did the relapse occur? Is it first relapse, second relapse, third relapse, and so on? How was the response to the prior therapy? Because depending on how the patient responded to the previous treatment will affect what you pick for the time of relapse. How aggressive is the relapse? Is it just a paraprotein going up, or is it lytic lesions, extramedullary disease? That will also affect what regimen you use. And what is the performance status of the patient? What kind of treatments can they withstand? And we take these factors to come up with a regimen that we'll use in a rational manner. Keep in mind that exactly which regimen you use may not be as important as making sure that you use a a well-validated triplet. And if one doesn't work, you move on to the other so that the patient gets the optimal combinations in sequence. In general, the principles are more important. Number one is you prefer triplets by and large, unless the patient is not able to withstand one. Number two, you use in the triplet at least two drugs that the patient's not already refractory to. Number three, transplant is a option for patients even at the time of relapse. Many patients have postponed stem cell transplant for later, and if they have stem cells available or can be collected, that should be always considered in eligible patients. And number four, we should consider clinical trials along the way, because many new drugs are coming up and patients may be eligible for one of these trials. The older drugs will always be available later for use. So given these principles, here is a summary slide which summarizes the current state of the art for relapse refractory myeloma, particularly in the first or second relapse, in terms of how we approach the patient. And I'll just walk you through this. The first consideration is the patient refractory to lenalidomide. So if the patient's already on lenalidomide and the relapse is occurring while they are on lenalidomide, you would use a different approach than if the patient is relapsing without any maintenance, without being refractory to lenalidomide. If the patient's condition is considered to be still sensitive to lenalidomide, the next one is, are they refractory to a monoclonal antibody? Many times, again, nowadays, we are using a monoclonal antibody in the first line setting, like patients are on Dara Lendex for frontline. So you might not be able to use this side of the algorithm, and you have to look at this side. If the patient's not refractory to lenalidomide and not refractory to CD38 monoclonal antibody, then daratumumab Lendex is the go-to regimen. This has got the best data from the Pollux trial. Patients can go 3 years or so with progression-free survival with this regimen. On the other hand, if they are already refractory to daratumumab, you might want to use a lenalidomide-based regimen that does not contain daratumumab, particularly one like carfilzomib Lendex, which has been shown in the Aspire trial to be a great regimen and often preferred for patients who are dara refractory but are not yet lenal refractory. By and large, nowadays, we are starting to see patients in the first and second relapses who are already refractory to dara and already refractory to lenalidomide. So how do we approach them? If the patient's refractory to lenalidomide and they're still sensitive to an anti-CD38 monoclonal antibody, you can use a regimen such as daratumumab carfilzomib dex or daratumumab pomalidomide dex. Now, there is another CD38 antibody that is approved called isatuximab. There's not much to choose between these two antibodies. For some patients, isatuximab might be much less expensive. So you look at what's commercially available, what is more cost effective for the patient when you make the decision. But either one is okay. And because they are already refractory to lenalidomide, you would combine it with either carfilzomib or pomalidomide. And on the right, more extreme, you have patients who are refractory to both lenalidomide and an anti-CD38 monoclonal antibody. Here, the options are more limited, and you may have to use a cyclophosphamide-containing regimen or a pomalidomide-containing regimen, like I have shown on the slide, KCD or KPD. Here is a slide that summarizes what do you do when patients are already refractory to bortezomib, lenalidomide, daratumumab, isatuximab, and carfilzomib. These are multi-drug refractory patients. What are the options? This slide was published in 2022 in the New England Journal of Medicine. Good summary. You can see here on the very top, drugs like selinexor, which is an XPO1 inhibitor, belantamab, which is an antibody drug conjugate against BCMA that are available, and then two CAR T cells, ide-cel and cilta-cel, that have been approved. These are investigational drugs that have also shown activity. These are bispecifics against BCMA or other targets. This slide was published in 2022, but it's already outdated because teclistamab, elranatamab, and talquetamab are all FDA approved now for use. And so what was investigational in 2022 is no longer investigational now. We are able to use these drugs. Now, one of these drugs, belantamab, has been withdrawn from the market, so it may become available later, but that was withdrawn due to uh, a phase 3 trial not showing activity as expected. How do we use these novel drugs in patients who are multi-drug refractory? The mainstay right now for patients who are already refractory to the standard treatments is immunotherapy using either CAR T cells or bispecifics. And I have listed here CAR T cells and bispecifics that are directed against BCMA. BCMA, or B cell maturation antigen, is an antigen that's present on all the myeloma cells. And you could target that by either CAR T cells, where you take the T cells from the patient, engineer them to go after BCMA and then reintroduce them, or a bispecific like teclistamab or elranatamab, which has two specificities. One arm targets BCMA, which is on the plasma cell, and one arm targets the CD3 on the T cells, bringing the T cell close to the plasma cell and delivering an apoptotic effect. So either of these strategies is good, and they both are effective, and they both go after BCMA. And this is now, we have a lot of data. All of them are FDA approved. All of them are FDA approved only for patients who've had at least 4 prior regimens. So this is approved for the 5th line. And that's why the first 4 lines, you have to have a good understanding of how we use them, so that when you get to the 5th line, you'll be able to choose one of these two. There have been a lot of data that have come out recently at the ASH meeting. This was just in December, looking at real world data. These are FDA approved, but how do these drugs perform in the real world? This is a study of about 800 patients receiving ide-cel, which is one of the 2 CAR Ts that are available. And you can see here a progression-free survival of 9 months for patients who have literally no other options left. And the median overall survival of 67%, which is also good, considering this is a real world study. Data for cilta-cel have also been, are also out and also show similar promise. What about bispecifics? Teclistamab, which is the first bispecific antibody to be approved by the FDA, was approved based on this trial, which shows that 60% of patients get a very good partial response, which is 90% reduction or better, and 63% have a partial response with this treatment. This is a bispecific against BCMA, and this is the result from the pivotal trial that was used to get accelerated approval. In the real world, data were presented at ASH this year, and they showed that you get a similar response rate, 64%, as was seen in the phase 2 trial. The progression-free survival seems shorter, about 4 months to 5 months. And this may be because of patient selection. You know, a lot of patients now have options to choose between CAR T cells and bispecifics. And if the patients have time to wait for the CAR T cells, we prefer the CAR T cells. If the patient's disease is very aggressive, we are preferentially picking the bispecifics. So the more aggressive patients are going on bispecifics. And that might be the reason why the PFS is shorter. We are learning to use these drugs. We will learn how to best use them, not just by themselves, but also in combinations. And so I expect these rates to improve. Now, we also have another bispecific approved called elranatamab. Elranatamab is very similar to teclistamab. There's really little to choose between them. It's very similar to the cetuximab and daratumumab that I described for anti-CD38. Similar high response rate, 61% partial response rate. A good option to choose between teclistamab and elranatamab. It really goes down to what is most cost effective for patients. For some insurance plans, one might be approved, the other is not, or one might be less expensive. So really, and also based on the side effects. So look at the patient and decide. There's not major things to choose between these two, but I'm glad we have 2 bispecifics that our patients have access to, and they both work really well. Given that these drugs work, cilta-cel, ide-cel, and the bispecifics work so well in the 5th line, can we use it in earlier lines of therapy? And if you use it in earlier lines, will the patients respond better? This is now a big question for us. And thankfully, we now have randomized controlled trials. This is a randomized controlled trial that was published in the New England Journal of Medicine just in the last year. And it looked at patients with 1 to 3 prior relapses and asked the question whether they'll do better with immunotherapy using a CAR T like cilta-cel or with the usual triplets that we talked about. And you can see that with cilta-cel, you get a much better progression-free survival. Now, we are waiting for the FDA to adjudicate these data and get approval for an earlier line of therapy. But this is really promising. One thing to keep in mind is when you use immunotherapy early, safety is important. We recently heard reports of T-cell lymphomas with CAR T-cell therapy. While that might not be important in the late-line relapses, as you move CAR T earlier on, that might be a consideration that the FDA takes into account. We also have reports of Parkinson's-like features and CNS toxicity. So I'm not sure that these are ready for prime time, but it gives you a window to what the future looks like, where we may be able to use some of these immunotherapy approaches earlier on. With ide-cel as well, there's been a randomized controlled trial that compared ide-cel to standard of care in the earlier lines of therapy, 2 to 4 lines, and you can see ide-cel doing better. One thing with this curve, and I think the cilta-cel may be no different, is that unlike large cell lymphoma or acute leukemia, CAR T-cell, even in the 1 to 3 prior lines or 2 to 4 prior lines, does not seem to be curative. There is no real plateau. Everybody almost eventually relapses. So that's kind of disappointing. We may have to keep working on how best to use these immunotherapy approaches and to see if we can get curative results with a different strategy. We are seeing now our patients who are not only refractory to all the proteasome inhibitors, immunomodulatory drugs, CD38s, but also to the BCMA strategies. They've already had CAR T, they've already had bispecifics. What do you do then? And thankfully, we now have a new bispecific. This is the most recent FDA approval called talquetamab. Talquetamab is a bispecific that targets GPRC5D, which is a different antigen on the plasma cell. So it gives you an opportunity to treat myeloma in patients who have already failed a BCMA-based approach. And then it targets CD3, so it brings the T cell next to the plasma cell in the same way. Again, you see very good responses with talquetamab, 70% response rates in patients with relapse refractory disease. The drug's also approved for 5th line now. The main problem with talquetamab, unlike teclistamab, is or the BCMA strategies. There, the main problem is infection and cytopenias. Here, the main problem appears to be skin toxicity, nail toxicity, not being able to eat well and losing weight. So we have to again work on the dosing and schedule for all the bispecifics, not just the BCMA bispecifics, but talquetamab as well, so that we find safe ways of using these drugs. Here is a summary slide which just shows you the type of progress that's been made. You know that myeloma had a survival of only about 2 or 3 years until bortezomib and lenalidomide came along. And you know, even before we had all these immunotherapy approaches, our median survival for standard risk patients was already 12 to 13 years. In the transplant eligible population, even for high risk patients, 7 or 8 years. So a lot of progress has been made. And that progress has been made with these drugs, lenalidomide, bortezomib, carfilzomib, daratumumab. Look at the single agent response rate activity of these drugs. We made these advances with drugs that had only a single agent response rate of 30-35%. Now we have a group of drugs, bispecifics and CAR Ts, which give you 60% response rates, better than any of these other drugs that we gave. So I'm optimistic that as we learn to use these drugs alone in combination in earlier lines of therapy, that the outcome of myeloma will improve further. Even if we are not curing patients, we'll prolong overall survival significantly. What are the main things to watch out for with the immunotherapy approaches as you use these in practice? One main thing that I told you is infection. This is an important study which looked at bispecific antibodies. This story might be similar for CAR T as well. This is from France, a very large study looking at real world what happened. Bispecific antibodies targeting BCMA 200 patients, GPRC5D in 29 patients. They looked at what happened to these patients. These are all patients who are in the usual age group for myeloma, all with multi-drug refractory disease. You can see here that cytokine release syndrome, that's CRS, and neurotoxicity, the ICANS, they occur in a certain number of patients, 60% for bispecifics, but lower rates of neurotoxicity than you see with CAR T when you use bispecifics. Steroid use is needed for controlling these symptoms in about 20% of patients, and tocilizumab in about 20-25% of patients. The main problem we see in bispecifics, as I said, is neutropenia, and neutropenia lasting more than 1 week is seen about 20% of patients, and that you should keep in mind. Infections are really the main problem. You can see that 70% of patients get some kind of infection within the first year, and much of that infection risk actually happens very soon within the first few months of starting therapy. And so we have to use prophylactic treatments to prevent infections in these patients and be aware of them. The infection risk seems to be higher with BCMA antibodies, BCMA bispecifics, than with GPRC5D bispecifics. And here is a multivariate analysis which shows that if you use steroids during the initial treatment, the risk goes up. But using antibacterial prophylaxis, IVIG, and so on, so will reduce the risk. And GPRC5D antibody has lower risk than using a bispecific. But again, most of us are reserving the GPRC5D antibody talquetamab only for patients who've already failed a BCMA-based approach. So we try CAR T and teclistamab or elranatamab first before jumping to the talquetamab, mainly because of the non-heme toxicities of skin toxicity, weight loss, and nail changes. Here is a summary slide of what I just covered. We talked about the initial approach. This is for patients who have disease that is already refractory to immunomodulatory drugs, proteasome inhibitors, and anti-CD38s. Really, the main option for these patients is a bispecific or a CAR T that targets BCMA. If belantamab becomes available later, that might be another option. So an anti-BCMA strategy is what you would do for patients who have got disease that's already refractory to these three standard lines. Sometimes, these drugs are approved in fifth line, so you may have to use a cyclophosphamide or some other strategy for the third and fourth line to get them to the fifth line so that you have insurance approval. That's just the reality right now. In patients who have disease that is already refractory to IMiD, PI, anti-CD38 alkylators, and BCMA, some of the other choices we have available are listed here. The main one right now is talquetamab, but there are some other drugs that we can use in combinations, elotuzumab, selinexor, venetoclax particularly, and only for patients who have the 11-14 translocation type of myeloma, bendamustine, some combination chemo approaches. Many of these are just bridging to get to talquetamab or some other approach. There are newer drugs that are all investigational coming up, which includes newer cell mods, iberdomide, mezigdomide, a newer bispecific targeting FcRH5, that's cevostamab, and newer CAR Ts. One of the newer CAR T, that is the GPRC5D CAR T, has been studied. There was an abstract at ASH, again showing significant response rate, 100% response rate in patients who had, even those who've had BCMA exposure, and a progression-free survival of 9 months. So there might be a newer CAR T that comes up soon, which gives options in addition to talquetamab. So the future looks good for relapse refractory myeloma. There's a lot that I've covered, but the algorithms that I showed will be useful for you in picking the right treatment for your patients. And in the live session, I will be able to answer any questions you may have. Thank you so much.
Thank Thank you, Dr. Rajkumar. A lot of very exciting things happening in the salvage setting. So we'd like to clarify a few things. So if I have a patient, which is going to be more common in the United States, who has relapsed on frontline quadruple regimens, how do you approach them? Can you go straight to the bites or to the CAR T cells, or it is prohibited at present? And does your approach depend on the duration of remission before the relapse and what type of therapy they are on at that present time?
Thanks so much for having me. It's a great question. Currently, bispecifics and CAR Ts are approved only for fifth line, so patients must have had 4 prior lines at least. Um, if a patient has received a quadruplet frontline, thankfully, most of those patients are not on a quadruplet when the relapse occurs. They've had the quadruplet for a while and they're only on len maintenance or bortezomib, so we can still come up with combinations that you can use. But if, let's say, they are relapsing while they are taking daratumumab, bortezomib, len, and dex, then since we are not able to use bispecifics and CAR Ts in the first relapse, we would usually try something like carfilzomib, pomalidomide, and dex, because carfilzomib can work when bortezomib doesn't. Pomalidomide can work when lenalidomide does not. So you come up with a regimen, even though it has an IMiD PI, it might work. Can use also add daratumumab to that. The second, if that doesn't work, then alkylator-based therapy can be tried, and that would be the third line with cyclophosphamide or melphalan-based therapy. And then we are usually struggling. So many times these patients go on what I think is suboptimal, like selinexor or elotuzumab or bendamustine, just to qualify the fourth line, and then we can move to the bispecifics and CAR Ts. We are constantly trying to convince insurance providers to approve the drugs earlier, and sometimes we are successful.
So let me ask you another question. What is your approach to biochemical relapse in patients with myeloma? When do you intervene for that?
It's a great question. For high risk patients, we like to keep them in complete response. So, any loss of complete response, we try to just go back to the treatment for relapse. If patients are standard risk and there is a pure biochemical relapse, the timing of intervention depends on how rapidly the monoclonal protein is going up. Generally, we wait till we see at least an IMWG criteria for progression. That's a half a gram increase in M spike or more, um, or development of some kind of symptoms or end organ damage, even if it's not symptomatic. Um, but more and more, these drugs are quite effective at relapse, and there's no hard and fast rule. But when the M spike is doubling over a 6 month period, or the M spike increases by half a gram or 1 gram, then we just go ahead with intervention in biochemical only as well.
Vincent, if you have a patient on a regimen that includes a CD38 antibody and they relapse 6 months after discontinuation, can you try again the CD38 antibody? How effective would that be? Would they be sensitive to that?
Yeah, this comes up often, like, whether it's like rituximab in lymphoma, where people use R-CHOP, then R-ICE, and so on. Um, with the CD38 antibodies, we don't have very good data if they're truly refractory, whether the CD38 would work. But many of us, because of want of other good options, tend to add them if we are able to. Um, and this will require some careful studies to see if that strategy is really, supported by this by data. There
And
are
what's your
patients, if
best
they've gone
approach?
6 months without, they could respond, so it's worth
What's
trying.
your best approach for a patient with plasma cell leukemia?
Plasma cell leukemia and extensive extramedullary disease, we still often do an aggressive multi-drug chemo approach first to get it under control, such as a DSAP or a VDT PACE, or even daratumumab plus CHOP. trying to give them a somewhat like a lymphoma type regimen to with anthracyclines to bring down the tumor burden before we try to use a more standard myeloma like approach.
Does bortezomib really need to be given on day 1, 4, 8, 15 instead of weekly?
Standard is weekly. We have a recent survey that we did. Most of the practitioners in the US give bortezomib once a week. And for many elderly patients, even that might be too much. We do 3 weeks on and 1 week off. And we prefer subcutaneous rather than IV.
And you and Sagar kept mentioning the myelosuppression and infections. Why can't we use prophylactic antibiotics and Neulaska like we do in leukemias?
For bispecifics and CAR-T, I think we should. Like, there is neutropenia, tackle it aggressively. IVIG for low immunoglobulin levels, prophylactic antivirals, antifungals, even live
On the duration of response or
not yet because they both are right now getting BCMA, but there are patients who have relapsed on BiTEs who have tried CAR-T and vice versa. There are a few patients who will respond in that fashion. But now with talquetamab available, I think some of those trials of TEC followed by TAL, TEC plus TAL, those studies are being done. And similarly with CAR-T against BCMA followed by GPRC5D bispecific.
Thank you very much, Vincent. We didn't get to all the questions, but that's all the time we have. So we will take a 10-minute break and we will come back at 10:20 for Dr. Steve Ansel's presentation on Hodgkin's lymphoma.